Hey, how you doing,
Good,
Rohan?
good. How are you?
Good.
How's things going on?
Good. So you ready?
Kind of.
Yeah. Well,
I
you know how it goes. You just say
Yes,
a few words.
few words.
Yeah, that's all. Who they are, where
Mm-hmm.
they're from,
Mm-hmm.
and the title of their talk. And then after they're finished, you say, okay, now it's time for any questions or comments. And uh, I'll be there, and there'll be other people there that can. I might say, hey, what do you say about this? I may ask people, you know, rather than because people tend to be shy. They don't want to ask anything, and especially students, which I understand. That most students prefer to stay in the background, which is fine. That's how it is. That's how medicine is.
Yes.
In the hospital. That's the reality of it. Not every student has their hands raised and talking. No, it doesn't happen. So how's it going? University of Nix. Now, where is that?
Nice. Uh, it's in Serbia. Serbia.
Serbia. Wow, that's an
Mm.
exciting part of the world to live in, huh? Used to be. They were at war just a while ago, like 10 years ago, right? Croatia,
Maybe
Serbia.
not sure. Yeah, Croatia, Serbia. There is Kosovo. Kosovo is the part which is like conflicted zone, and
Right.
yeah.
Okay. Okay. And you're
So
in
I'll just give
sixth.
a quick intro.
You want to give a quick intro right now?
Quick demo, just a demo, so that you can correct if anything goes other way. So first
Uh,
speaker will be Dr. Surat Mansinghe. He is originally from Sri Lanka, a neurosurgeon from Sri Lanka. And today's his topic will be neurosurgery under difficult circumstances, thriving through inspiration. So over to you,
yes.
Dr.
Say a
Mansinghe.
little bit about what he's a general neurosurgeon
He's a
that
general.
has an interest in spine, I think. Look at his profile, okay?
Okay.
You just get and look at the profile of Bushan Tambien. Just
Bhushan Thombre
the
as well.
highlights. For example,
Yeah.
Bushan likes to talk about artificial intelligence.
Okay.
That's his interests, and that's what he's going to
Yes.
talk about today. So yeah, just take a few minutes and look them over. We won't have a lot of people, but that's okay
Okay.
as long as
So
we
yeah.
go ahead. Go ahead.
So he is trained in the UK. He did his, I think, fellowship in neurosurgery at King's College Hospital, and he has worked for a year there, followed by returning back to Sri Lanka. And yeah,
Yeah,
continue.
move your camera. Your face is too close to the camera. Your face is really big. Okay, move it. Position it. That's good. A little lower. Lower.
Yeah,
Position your camera a little lower.
little
That's good.
lower.
That's good. That's good. That's good.
That's okay.
Yeah. Just how it looks on the screen. So sixth year, are you graduating after this year?
Yeah, I'm graduating this year,
Okay.
hopefully.
Any
Yes.
idea where you're going to go next?
I have applied for a research technologist position at Barrow, and there is a postdoc position at MD Anderson with 3 LORs now. So I am waiting. Currently, I am at Istanbul Medipol University doing my Erasmus exchange for 2 months, completing, yeah,
Were you excited? It's a big time in your life.
it's going well. It's going well.
Okay,
It started as an,
Sardar Ali. Sardar
yes.
Ali. Hello, Sardar. Okay, I don't know if you want to turn your camera on, Sardar, but you're welcome to if you'd like. And if you'd like to come in the panel, you don't have to. You can just watch anonymously. That's okay. They can just watch anonymously.
Yes, I'm ready.
Yes, we can hear you. Your voice is not clear, Sardar.
Is it a big school you're going to?
No, it's
How,
like,
how many students in a class? 100, 200?
yeah, it's 100 international cohort, and the local cohort will be another 100, I guess, each year. So yeah, in total it's 200, but the capacity, like in terms of infrastructure, is not that much. I think that would cater it. So yeah, but we are managing that.
Oh, okay. Some students from all over the world or mostly from Serbia?
We can say from different parts of the world. Most of them are Indians going to Serbia. There are also from Pakistan students. Uh, they are studying. Some are like UK Indians, UK Pakistani. So those nationalities are studying there as well. But yeah, majority makes up them. Then the other will be like Germany, Finland, and Holland, and other parts of the country as well. There are also from Tunisia and Egypt, I guess, maybe someone. I don't know, but Tunisia, yes. Uh, Turkey, yes. And yeah, so yeah, there
And
is a mixed cohort.
the lectures are in English or
English, yes,
Serbian?
yes, yes.
Okay,
They are
that's
in
good. Well, that was a big plus for you, right? You look for a
yeah,
school. Uh,
English, yeah, curriculum.
yeah, well, yeah, some students go to countries where they have to learn Russian, or another like Chinese even.
Yeah.
Imagine that trying to learn medicine and a language at the same time. But students do it. They do it. I went to
So for
school in
patient,
Mexico, which was
okay,
Spanish. It was funny because the class would have 40 Americans in it, and they spoke Spanish. They wouldn't speak English. They just spoke Spanish. That was the school. Everything is in Spanish, no English. So, but that was okay. After English is very similar to Spanish, especially in medicine, like a
okay.
stomago, esophago. I mean, things are very similar. Whereas I think if you had to learn the local dialect, it'd be different than English, very different. Like, do you speak is the language Serbian, right? Serbian?
We do speak some basic Serbian so that we can interact, but we mostly currently use Google Translate to interact with patients. And yeah, sometimes professors or doctors help us to translate what the patient complaints are, or yeah, or interns, any resident doctors may help. But mostly we use Google Translate. So yeah,
Do you like living there? You like the food and everything?
we usually prepare our food on, like, I usually prepare my food, and most of the students as well, they prepare their own food. And yeah,
Now, you must have a pretty tight Indian community there, right? About the
yes,
students.
yes.
It's like another city in India.
It's kind of, it feels like it kind of, yeah.
You're from Delhi?
I'm from Mumbai.
Oh, Mumbai,
Yes.
big city. A lot of neurosurgeons there. I really like Dio Pujari, Chandra Dio Pujari from Mumbai. And of
Okay.
course, Goel is from Mumbai. You know
Go ahead.
that.
Yes, yes, yes.
He's a good guy to get to know.
Yeah, I have a research project ongoing with him. So yeah.
He's very friendly. If you want to get to know him, don't be shy. Say, hey, I'm Rohan. He'll remember you.
Yes, yes. I did approached him on his email ID for a research project. Currently doing a research project on Chiari malformation as a narrative review. So hopefully that or a systematic review if turns out to be systematic. If things go according to Prisma, otherwise turn it around to narrative review.
That's good. Well, you can get to know, with the internet, you can get to know these people.
Yes,
Before you
yes.
couldn't, you'd have to go to the
Good.
hospital, go to their office. Now it's like you meet them right online. So it's a big
Yeah.
advantage for you students now, which, most students, like I say, are shy. I understand that. And they won't really go up to the professors. They feel intimidated. But if you approach them, they're very friendly because they've been where you've been at, asking their seniors for advice or help or whatever, connections. Because a lot of these big ones, they receive emails and they don't know who you are. They look at your resume, that's it, that's all they got. But if you just meet them once, hey, Dr. Well, they'll remember you when you write back to them for a favor or for a letter of recommendation. And of course, if you're active, they'll say that. If you just say, hey, I went to this conference and that conference, and so they can write you a good letter, that has some meaning to it. You're not just another email. But
I am that's why trying to go to the Congress of Neurological Surgeons this year, but I have to see how I figure out the visa thing because coming, okay, Dr. Surat is here.
yeah,
Let me know.
okay. Yeah, we won't start for about 3 or 4 minutes. Hello, Sarath.
Hi, John. How are you?
Good. How you been?
Good. I'm good. It's a
Hey,
little bit busy
listen,
these days.
listen. Do you want to? You can lecture on skull base, right?
Sorry, I didn't get it.
Can you lecture on skull base topics?
Yes, of course.
Okay. I'd like to invite you to a conference. I'll send you the information. Uh,
Is it the one organized by Dr. Sami?
yeah, yeah, that's it.
Yeah,
I'll send you the information,
sure. Thanks a
and you
lot.
and you get a slot. He'll give you a slot. And Rohan
Thanks.
Main, he's a student, Indian student from Mumbai. He's currently at University of Nix
Yes.
in Serbia. He's going to be moderating.
Hi, Rohan.
Like, greetings, Dr. Surat.
I was telling him, Sarath, that most students are shy, but
Is that so?
I'm saying that these are good people to talk to. They're friendly. If you ask them a question, they've been there before. They know what it's like to ask for help or for whatever. So it's good to get to know their face.
That's right.
It's a plus. If you had, like I'm sure, if you had to do it again, you'd probably do that too.
Of course.
And now we got the tools to do it. Now we got the tools. We didn't have these tools when I went to school, like 30, 40 years ago, they didn't have this stuff. No, 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 no.
Yeah, now they have a big opportunity through these social media platforms and these online webinars. So we
Yes.
didn't have that in the past. So they have a very good opportunity to come up.
Yes. Okay, we have, okay. Okay, I guess you go first. We're waiting for Bushan. Oh, okay. Yeah, yeah. Oh, shit. Oh, Alta, are you there? Alta, are you there? We can see. So you'll be the first speaker, Sarath, okay? Okay, let's start,
All right.
let's start now, okay? Okay, 10, 9, 8, 7, 6, 5, 4. Oh, hold on. What? Yeah. They changed something on me. They changed the, wow. They'll change, Zoom will change things. They won't say anything. Start review, raise hand. Okay. More live stream polls, record. Oh, okay, they changed the menu. Okay, okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach. We have another in the Neurosurgery Aspirant students and residents that are contemplating a career in neurosurgery. And we have a student, Rohan Main. He's originally from Mumbai. He's currently at University of Nix in Serbia. He'll be moderating today. Good day, Rohan.
Greetings, Dr. John. Nice to meet you. So, to introduce Dr. Surat Munasinghe, he did his MBBS from University of Sri Jayawardhanapura from Sri Lanka. Following it, he did his surgery residency and neurosurgery senior registrar in National Hospital Sri Lanka. Following it, he did his fellowship at King's College Hospital, NHS Foundation Trust, and Special Registrar in Neurosurgery at Queen Square, London, UK. Currently, he is a consultant neurosurgeon in Sri Lanka. Over to you, Dr. Surat Monasanghe.
Thank you, Rohan, for the introduction, and thank you, John, as always, for the opportunity. So, even though it was very short notice, uh, I can't say no to you. So, today, actually, the audience is mainly the neurosurgery aspirants. So, I have made the things very simple. So, I have presented most of the contents somewhere else in the meetings and the webinars, but I think they'll be very useful for the beginners, especially for the young people who are aspiring to be neurosurgeons. So, let me share my screen. I hope you can
Perfect.
see my screen.
Yeah, perfect.
Right. Right. So the topic is actually driving through inspiration because most of the people, when you become young neurosurgeons, you might have to go through some difficult times initially in your career. And there are few tips and tricks and advices from myself, learning from the mistakes and from the things what I have learned. So, how to be a safe and a better surgeon? So, if you are aspiring to be a neurosurgeon or what any kind of a surgeon, first of all, I think number one thing is you need to be a safe surgeon. First of all, you need to think about safety of your patients. And remember, in neurosurgery, the most important aspect is patient's outcome. So you may be doing a perfect surgery, but the outcome of the patient may not be good. So patient outcome is the most important aspect, according to my vision. So if you want to achieve the best outcome for your patients, first of all, you need to have a sound knowledge of what you're doing. You should be doing, you should be knowing what you're doing, right? So you should be knowing what you cut, because as a surgeon, as a neurosurgeon, you deal with the brain and the spine, the most critical and the important structures of the body. So you have to have a sound and a thorough knowledge of what you're doing. In that case, you need to have a thorough understanding of the anatomy. So anatomy is very, very important for any neurosurgeon. So if you want to be a neurosurgeon, this is the best time in your medical student period, as a resident, as a fellow, you need to gain this 3D knowledge, the three-dimensional view of the brain and the understanding. That is very, very critical. As a neurosurgeon, remember, very, very important. And the next thing, a proper planning. When you want to operate, maybe it may not be a complicated case, but maybe apparently a simple case. Any kind of a neurosurgical case, you need to have a proper planning, especially when it comes to complicated cases and complex cases. You can't do neurosurgery or you can't operate on a neurosurgical patient without a proper planning. That you have to do that homework before you place your scalpel on the patient's skin, patient's scalp or the spine. Remember that. And my friend, remember, when you in your career as a neurosurgeon, you might realize this. Correct decision making is the most important aspect as a neurosurgeon, or I would say any surgeon. If you make the wrong decision, you will make a mess in your patient's life. So remember, decision making is very, very crucial in your career. You have to have a sound surgical technique, of course. You have to be a skilled person. You have to be a skilled surgeon. But remember, each and every surgeon is not skilled similarly, right? So the skill depends and skill differs from person to person. Especially if you are a neurosurgeon, you need to have excellent composure and a mindset throughout your surgery. You have to have patience. You need to develop patience, right? And you need to admit your mistakes and you need to learn from your mistakes, right? So if you don't learn from your mistakes, you will never going to, you are never going to be a better neurosurgeon. Always be ready and flexible to change, right? You should be flexible as a surgeon, as a neurosurgeon. You should be able to change, right? And you should be ready and to be able, you should be able to manage the complications. If you make a complication, it's quite, I mean, it's not unusual for us to make mistakes because we all are humans and we do make mistakes and we do, I mean, we come across complications in our cases. But getting a complication is not a big deal, but you should be able to manage the complication. So if you are not being able to manage complication, you should not be doing that. And remember, you need to do research and long-term follow-up in your patients. So you can't just forget your patients after the surgery. You operate And then you can't just ignore or neglect. You need to have a long-term follow-up of your patient. So these are the keys and these are the basics as a young neurosurgeon that you always need to follow. And there are so many challenges, especially as a young neurosurgeon. So in countries like Sri Lanka, India, I don't know the situation in the other countries, but mainly in LMIC, you usually start your career from a peripheral center as a young neurosurgeon. You cannot come to the center because you will be placed in a faraway place, maybe a peripheral center. So in those centers, the facilities may be distributed unevenly. So if you go to a peripheral hospital, the infrastructure can be poor and the living conditions may be less amenable and the environment may not be that friendly for the neurosurgeons. And most of the time in my country, so we have a lack of neurosurgeons. So most of the times we are the only neurosurgeon in the peripheral center. So you are the solo neurosurgeon. So, but you have lots of work. The increased workload, sometimes you might feel physically and mentally exhausted. Uh, and also, the earnings may not be adequate as you aspire. So these are the challenges that you need to overcome. And how to overcome these challenges and become a good neurosurgeon. So first of all, let me give you my opinion on a good neurosurgeon. So in my opinion, a good neurosurgeon is a safe surgeon. First, he has to be a safe surgeon and a skilled surgeon with a sound exposure and with correct attitude towards patients. So you have to have the correct attitude towards the patient. So remember, the most important aspect in your career is patient. Patient are the most important aspect in your setup. Without the patient, nothing will be there. So always perceive the difficulties as inevitable challenges, not as a drawback. So as I mentioned before, do no harm. Become a safe surgeon first. So always think, if it happens unto you, if it happens unto your family member, what is your management? What will you do? So always think about it. Always think like that. And as I mentioned earlier, decision making is the most important aspect of a neurosurgeon's life. And attitude matters most than the skills. So always think about patient outcome, as I mentioned before. So I remember once, maybe 3 years back, I was listening to Dr. Sushil Patka, the Indian neurosurgeon, in a young neurosurgeons forum. He was talking about three A's, the basics of any neurosurgeon. Number one, first A is available. As a neurosurgeon, you should be available. Then you should be affable. Then you should be able. So ability comes third, not first. So how much you are skilled, if you are not available, then that's no point. It's immaterial. If you are not affable to your patients, if your communication is not good, however skilled you are, it's not going to help your patients. It's immaterial. So first you should be available, then you should be affable, then you should be able. Right. So think that you being appointed as a neurosurgeon, a young neurosurgeon, maybe your first appointment, and you go to a place, maybe you are the solo neurosurgeon and you want to make an impact. You want to make a change in your workplace. So if you want to make a change, you need to have a vision, a very good vision. You need to have the skills. You need to have the incentives. You need to have your resources, and definitely you need to have an action plan. If you don't have a vision, you end up in confusion. If you don't have skills, you're anxious. You end up in anxiety. If you don't have the incentives, you feel resistant. And if you don't have the resources, that's what happens to us most of the time in LMI. So you end up in frustration. And if you don't have an action plan, your start will be false. So if you don't have the resources, that's what happened to neurosurgeons in LMIC. Your lack of resources, then you need to innovate. You need to change. You need to look for alternatives. And then you can prevent frustration. And within the next few slides, I'll show you how I have overcome this problem, this lack of infrastructure and the resources, which is mainly the essence of my topic today. So these are the drawbacks, innovations, and alternatives that I experienced and what I learned. So in my hospital, I can remember 8 years back, I was appointed in the eastern province of Sri Lanka as the solo neurosurgeon. Soon after my fellowship in Queen's Care, London, I was posted in Batticaloa Teaching Hospital, which is the single neurosurgical center for the entire eastern province. So I had these difficulties, these drawbacks. So I didn't have general anesthesia facilities round the clock. So I used to operate under local anesthesia. I'll show you. And lack of ICU facilities is a big problem in most of our neurosurgical centers in the peripheries. So what I did, I tried to operate under local anesthesia, and we tried to do early tracheostomy or tracheostomy even at the time of surgery when I felt the prognosis is not going to be good, the patient will be in ICUs for a long period of time. So we did the early tracheostomy in those situations, because most of the time, even though the patient is sent to the ICU, most of the time they've been mobilized early back to the ward because of the limitations. And then I used to do these keyhole approaches. I'll show you, especially intracerebral hemorrhages. And we had a lot of delays in getting our MRIs done, so I had to operate without MRI in some situations to save the patient's life. And we had this problem with lack of hardware for instrumentation. So I tried to use these autographs as much as possible, like pericranium and the fascia lata, instead of these dural grafts for dural repair. And for cervical corpectomies, I used to get these fibular grafts and had excellent results. And most of the places I worked with the peripheries, they did not have a navigator to guide us. So I used craniometric points instead the navigator. And we didn't have a endoscope in some peripheral hospitals, so I used keyhole microscopic approaches instead, and some temporizing measures in critical conditions like in aneurysms. And so always I trust in my skill and acumen rather than the technology. So these were a few examples. So I can remember in cervical dislocations, when I was working in Batticaloa, the eastern province, we didn't have the instruments to perform anterior cervical procedures. So I didn't take it as a disadvantage. So I was doing closed reduction and posterior fixation in all those cases, and I learned something, and I did research on it. I did the posterior fixations, and I had a series. I'm not going to show it today, but I have presented it so many times. And uh, sometimes we didn't have posterior instrumentation in some hospitals, so the only option was laminectomy for the cervical procedures. So I started doing laminoplasty instead of laminectomy. And I had to operate tumors without MRI because MRI machine was not available. So we had to send patients 100 kilometers away for an MRI, the next available the hospital. But some patients, they couldn't wait for days and days, weeks and months to get an MRI done. So I had to operate without MRI. Another example is cystinostomy. I started doing cystinostomy mainly to avoid cranioplasty at that time, because I did not have facilities to keep the bone flaps in refrigerators, because the condition of the refrigerators was not that good. And titanium mesh is very expensive. So most of the patients could not afford it. So I started doing cystinostomy, mainly to avoid cranioplasties, but I had very good neurological outcomes with cystinostomy. So it was an added advantage because I was able to avoid cranioplasty most of the time. And as I said, I started doing minimal access ICH evacuation. Most of the time it was under local anesthesia. I'll show you in the next few slides. So what are the strategies to enhance outcomes? So as a young neurosurgeon, these are the things that you need to uh, focus on. So early in your career, right? So if even you are a neurosurgical resident, a fellow, learn these techniques. So learn the correct positioning techniques from the beginning, right? Whatever the position, learn it correctly. Remember, learn how to mark the incision. You may not be having a navigator all the time, but depend on the craniometric points, right? Remember, you need an adequate exposure as a beginner. Adequate exposure doesn't always means a big exposure, right? So even a mini craniotomy might be enough, but first of all, you need to have a thorough knowledge on your anatomy. And then always remember, when you start your career, always try to have a good exposure. Don't try to do it with a very small incision and get into trouble. You can do it once you become a master. Once you master the techniques, you can do even with a small incision, even microscopically without the endoscope. You might be able to do most of those cases, because you may not be having an endoscope always in your centers. So adequate exposure, remember drilling the sphenoid bridge. These are few examples. Selectively, you can do anti-reclinodectomy when it is indicated and necessary, and master the cisternal openings for CSF release, right? So sharp dissection techniques are critical and important. For an example, Sylvian Fisher dissection. And always follow the principles, right? So you need to always follow the principles. And gentle handling in neurosurgery, gentle handling, I think I don't need to stress that. Everyone knows. So patience is important. And as I mentioned, learn to innovate when necessary and gradually learn when to stop and when not to operate as you gain experience. And always remember, you need to review, you need to research, and you need to rectify. So without review, without research, you will not be able to rectify yourself. And always try to be yourself, because you can follow someone, but you can't become someone else. You have to be your own. So be yourself, but you can follow uh, the great mentors. You need to do that and appreciate your patient's outcome more than your post-operative images. So don't try to make your images better. Always try to make your patients better. Now let's get into some scenarios. So through these scenarios, I will explain how I was able to overcome these difficulties and drawbacks, because I had a very difficult time, because for the last 7, 8 years, I was working in the peripheral centers of Sri Lanka as a solo neurosurgeon. Now I'm working in the center in Colombo, the National Hospital of Colombo. But I had a very difficult time uh, working in these peripheral centers. So I'll show you the things I learned, and I hope that will be useful, helpful to you as neurosurgery uh, aspirants. So operating tumors, one second. So operating tumors without the preoperative MRI. So this is not very uncommon situation in some parts of my country. So for example, you can see this is a CT, non-contrast CT. It's a large tumor in the anterior uh, skull base. So this patient, I remember, this patient presented to me 8 months back uh, to this the day of we took this CT scan with a moderate sized tumor. And we planned to do an MRI because the MRI facilities was not there at that time. So we planned to send this patient to a center where the MRI facilities is available, that is Kandy, which is 100 kilometers away. So we sent this patient, but this patient never came back. And suddenly, after 8 months, this patient came with a GCS of 3 to the ETU. So this is what the CT scan showed. You can see almost almost with this infarction and all. So then I decided I should not be sending these patients, some of these patients selectively to a different center for MRI, because most of the time I have seen they never come back, or they come back with this type of situation. So where there is very minimal that we could offer to this patient, and this patient passed away. So in selectively, some of the patients I started operating without a preoperative MRI. So these are few situations. These patients comes with low GCS, so most of the time we cannot send these patients far away. So I started operating without a preoperative MRI. And most people were asking me when I presented this, how are you going to operate on a tumor without an MRI? Yeah, that is not easy. It's a bit difficult because the information you can gather from a CT without an MRI is less. But it doesn't mean that you cannot operate without an MRI. So this is the pre-op and this is the post-op, and this is the patient post-operatively. I can show you so many case scenarios like this. This is again a giant olfactory groove meningioma. This is preoperative contrast CT. This is in 1 year follow-up, and this is after 2 year follow-up. Now this patient is coming to me even after 5 years for follow-up, and she has no recurrence. So this is another case. You can see this is a non-contrast CT. These patients presenting with low GCS, and I had to operate with the CT. And this is the post-operative. This is the immediate post-op on your right-hand side. And all these patients survived. So this patient, you can see, this is a non-contrast CT in the posterior fossa. I'm sure you can see that. So this is a large meningioma in the posterior fossa. This patient presented with a GCS of 5. And I had to operate even without a contrast CT because we had problems with ICU. So I had to operate as early as possible. And this is the patient. So post-operatively, she survived, right? So this is another case. I'm sure you can see this cavernous sinus tumor, right? On the left side. This is the only image available at that time. This is actually 8 years back. You can see she was presenting with rapid loss of vision and ptosis. She's the sole breadwinner. Uh, she's a widow having 7 children, the sole breadwinner of the family. So I couldn't wait and for an MRI, and I had to operate even with that image. So this is the immediate post-op. This you can see after 4 years post-op. So you can see the image speaks, right? So I don't have even the post-operative image of this patient, but you can see clinically the improvement. Right. So remember, if you don't have a facility, it doesn't mean that you should not be doing what you are able to do, right? So don't lose heart. Do whatever you can with the available resources, right? Always think about the patient's outcome. That comes first, right? So another scenario I can show you. I think I have spoken about this on various platforms. Minimal access open microscopic evacuation. So you can see these are hypertensive intracerebral hemorrhages, right? And I have been doing evacuation of these hematomas through a small burr hole. I would say a burr hole or a very small mini craniotomy, slightly larger than a burr hole. You can see the picture here with the aid of the microscope. Right? So I would say it's minimal access, open. It's not endoscopic, it's open. So you can see this is the post-op on your right-hand side. You can see the opening is very, very small. It's frontal nowadays. I used to use a temporal burr hole when I started doing this initially, but now I have shifted to a frontal burr hole. So you can see this is the incision I make. So what's the advantage of doing this type of thing? So most of the time I do this under local anesthesia because I don't want to do it under local anesthesia, right? I don't like to do it under local anesthesia because it's not easy, it's difficult. But I was compelled to do because sometimes I was not having a general anesthesia throughout the clock, right? So I had to operate it under local anesthesia. And we had issues with the ICUs. The ICUs are limited. So I had to operate under local anesthesia, and sometimes I had to do a tracheostomy, even under local anesthesia at the same time, right? So with that, we have saved lots of patients. I can tell you, I can show you all the evidence. We have saved lots of patients because I have seen patients dying in front of my eyes, right? Not because of the ICH, because of the complications of this ICH, right? Because most of these patients first come to the medical ward because we don't have the capacity to get all these patients to a neurosurgical ward. So most of the patients, they do not die because of this ICH. They die because of the respiratory complications. They die because of aspiration pneumonia, even before we intervene. So I was trying to find a method, a quick method which is simple and safe to get rid of the hematoma volume. So the secondary effects of these toxic metabolites and the hematoma, the damage is being minimized. So I was trying to evacuate these clots as early as possible whenever it's indicated, right? Whenever it's indicated. So we had the criteria. I did my study on this, and we have the indications, right? We have the indications to intervene, and this is what we did. So it's a very small incision. Sometimes general anesthesia it is available, and sometimes under sedations, and sometimes it's under local anesthesia, unfortunately. But we saved lots of patients. You can see I can show you so many examples, right? This is the size of the bone window. And here you can see this is a recent one. This is done last year. The frontal opening. Going through the frontal burr hole is not easy. It's a bit difficult because you can see from the entry point, the distance to the target is more, right? And but the manipulation is easier with your instruments, with your diatomy and with your sucker and the whatever the rongers, the instrument. The manipulation is easier. And remember, all these cases I have done without using a navigator because I did not have the navigator until this year, until I come to National Hospital of Sri Lanka. I didn't have the navigator. So this is what I do. It's a very short video. So you can see the local anesthetic being infiltrated. And it's a very small incision. You can see I have marked incision depending on the craniometric points. If you have the navigator, you can use the navigator. It's easy, but this is the burr hole I make. And this is the opening in the bone, right? So it's a very small, you can say it's just bigger than a burr hole. So it's a mini craniotomy. So if you are in the correct position, if you have marked your position correctly, then you can directly go into the clot. Once you reach the clot, make sure you don't do any collateral damage to the brain with your instruments. So what I do is I use the sucker in my one hand and a ronger or even a bipolar on my right hand to get rid of the clot. So you have to be patient because of the pressure inside the brain. The clot will come towards you. Clot will come out. So you have to be patient. And the most important aspect of this surgery is achieving hemostasis. So you have to spend around 5 to 10 minutes for the hemostasis, and then you just put the piece of bone floating, and that's the end of the surgery. So you can see this is the pre-op, and this is the pre-op the CT, and this is the post-op CT. So this is the case I showed you the video. So I can show you so many examples. So this is the pre-op and this is the post-op. So you can see through the frontal burr hole, you can do a near total evacuation of the clot. So this is another case you can see, but you don't need to get rid of the whole clot, right? Even 80% of the clot, if you take out the 80% of the clot, I think that's enough. You can see another case, right? Most of us never thought that this patient would survive, but this patient survived. So this you can see this pre-op and this is post-op. So initially, if I don't have the theater facilities, right, I inserted an EVD and then to reduce the pressure, and then the next day we remove the clot. So this is the patient. So that patient survived, even though with disability, we saved his life. You can see another case, preoperative GCS is 7. It's dominant hemisphere hypertensive ICH. So this is the post-op on your right side. You can see the entry point here, and you can see this is immediate post-op. So near total evacuation of ICH, but most importantly, what is important is this patient survived. But you can see most of these patients being tracheostomized. So that is another aspect in our cases, in our ICH cases. So this is my experience. And up to 2024, December 2024, we had operated 373 cases of hypertensive intracerebral hemorrhage. So remember, all these are hypertensive intracerebral hemorrhages. not traumatic or any other case. So the 30-day mortality in my case was 12.5%, and 6 months mortality rate was 16%. So 60% of patients roughly had a favorable MRI score, 6 months follow-up. So compared to the routine, the mortality rates, I think these are very, very good neurological outcomes. Right. So that's all about hypertensive ICH. And let's move into another scenario. Thick subarachnoid hemorrhage due to aneurysm rupture. So especially patients with poor Hunt and Hess grades, poor WFNS grade, especially old people, when they come with this thick subarachnoid hemorrhage and low GCS, these people I have seen, they usually die even before we uh, proceed with a CT angiogram. So most of the time, we were unable to find an ICU bed for these patients as well. So in that case, what I did was I did a decompressive craniectomy on the dominant side initially to buy some time, right? And then we did the CT angiogram, and then we did the aneurysm clipping. So this is one of those cases. We have done around 10 to 15 cases, and we were able to save these patients most of the time. So you can see this is after left-sided decompressive craniectomy, and then we did the aneurysm clipping of these patients after the CT angiogram was done. So this is another scenario. You can see it's very thick subarachnoid hemorrhage. These patients, they deteriorate very quickly. They deteriorate very, very quickly. So you can see again, we have done the decompressive craniectomy on the dominant side. This patient, I can tell you, so this was done a few years back, and you can see the CT angiogram. So the CT machine we had, this was in few years back when I was working in Ratnapura, which is a peripheral center, we had only a 16 slice CT scanner. But you can see here the impression is normal CT angiogram, right? No aneurysm seen. So that's I mean, that's what happened most of the time, right? Thick subarachnoid hemorrhage. So it's very unlikely that there is no aneurysm in these type of cases. Clinically, that's your clinical uh, the clinical picture. But when you do a DSA, most of the time they become positive because it is not because uh, of anything else, that is because of the less accuracy of these the CT angiogram machines. But unfortunately, this patient again. Uh, uh, this patient did well after the decompressive craniectomy, but this patient suddenly deteriorated. Most probably, we thought with the CT findings, it is a re-rupture of the aneurysm. So even though the CT angiogram says normal, I had to, using my clinical sense, I had to reopen. I had to go and look for any aneurysm because the patient was not able to transfer for a DSA to Colombo, and this is what we saw, right? So you can see there's an internal carotid artery aneurysm there. So the aneurysm was clipped, and the patient was saved. So always you need to have your clinical sense, and you have to believe in your clinical sense sometimes rather than depending on your technology and the reports, right? So another scenario you can see, this is a patient with an AVM. So this is the CT angiogram. This is the CT angiogram that we had when I was working in my peripheral hospital. So I mean, you can't expect more than this from a 16 slice CT scanner. It's very limited information you can gather from it, and this is what we what we saw clinically, and this is the patient, and he survived after the AVM resection. So in these type of cases, you need to have a very good knowledge of your three-dimensional anatomy, and you need to you need to trust yourself, and you need to depend on your clinical acumen most of the times. Let's get into another scenario, cystostomy. As I mentioned earlier, I told you that I started doing cystostomy mainly in terms of reducing the incidence of cranioplasties. But this is my inspiration for cranioplasty. This is in 2020. This is a young girl, 18 years old girl, presented with the GCS of 3 following road traffic accident. You can see it's a very bad CT, even though the SDH is thin. And this is what we did. We did the cystostomy. This is my first cystostomy. I can see the drain, the EVD in the prepontine cistern, but I didn't put the bone flap back at that time because I had to be honest, I did not have much faith at that time because it was a new technique for me. Even though I knew about it, I had not practiced that before. But you can see this is after 26 days, right? So we were able to do put the bone flap back, right? So early, ultra early, and this is the patient. So she survived. She had a remarkable recovery, right? So this is the patient, made a remarkable recovery in very, very quickly. So this is my inspiration to do cranioplasty. And we did so many cranioplasties after that. So Professor Aipchirian, I'm very grateful to him, my good friend. So learn a lot from him. So more than 200 cases over the last 4 years. And additional benefit is marked reduction in the number of cranioplasties as well. So after some time, I used to put the bone flap back at the same time. So the reduction in number of cranioplasty is 27%. And another scenario. So I used to use fibula as a graft material in anterior cervical spine surgeries when I did not have the scopectomy cases. So you can see several cases where I used fibula graft, which actually served as an excellent graft material. I can assure you, the fibula is an excellent graft material. If you don't have the proper instruments like scopectomy cages, you can always use fibula and also the iliac bones, right? So these are few cervical spine instrumentations that I did when I was in Teaching Hospital Ratnapura few years back. You can see the pedicle screws being inserted. Just to show you, when I took over my duties as the single neurosurgeon in Ratnapura in 2020, there were only few instrumentations performed, maybe totally around 10 instrumentations performed. And this is after I took over in 2020, and within that 4 years, until 2024, I had done 428 cases, including the most complicated cases. So it's not all about numbers, but it's all about the inspiration. And if you have the inspiration, if you have uh, your expectations, right, nothing is impossible, right? And few tips as we gain the experience, right? So this case, actually, this is a patient with a basilar tip aneurysm, right? So, excuse me. So this is a patient presented with a basilar tip aneurysm, and you can see the incision, as I said earlier. Exposure is not always about the size of the incision or the size of the craniotomy. Remember, when you gain experience, it's about adequate exposure. So even with a mini craniotomy, you can do. So I have done so many cases with this mini craniotomy, mini pterional craniotomy, right? So remember, it's always adequate exposure. But when you begin your career, remember, you need to have a good exposure, right? You might not be able to do it with a small incision or a small craniotomy, but it doesn't matter. When you start your career, always be safe, be a safe neurosurgeon. That is the most important thing, right? So this is cisternal opening, as I mentioned, opening of the cisterns to release CSF and to make brain relaxed it's very, very critical. These are the basics that you need to learn and you need to practice in your from very early in your career, right? So you can see this is the type of dissection we expect. So you can see the optic nerves, the carotid arteries, and you can see the membrane of Lilicus being opened, and you can see the basilar artery there as well. So sharp dissection, you need to master the Sylvian fissure dissection and the dissection techniques, right? So again, CSF release from the cisterns, as we talked about, right? You may not be having, these sophisticated instruments, but the basic instruments are enough, right? You may not believe that for the last 4 years, wherever I was in Ratnapura, this is the only, the dissector I had. The only, the what you call this, uh, the scissors, the micro scissors. I had only just one micro scissor, and I did all these surgeries with that. Right, so think about this type of lesion, this type of sphenoid wing meningioma, where the all these the blood vessels, the ICA, the ACA, and the MCA being engulfed by the tumor. So this type of a tumor, you need a lot of homework, right, before you embark on this. You need to study this, right? You need a preoperative workup, right? You don't take any chance, especially when you are working under, restricted environment. You can't take a chance in these patients, right? So you can see I have not put the bone plug in this case because I expected some brain swelling. But this is the post-operative video after 24 hours. You can see the whole tumor was taken out. And this is a very, very firm tumor. It's not easy, right? So this was done without the CUSA, right? Because the CUSA machine is not, most of the time it was not functioning. But these are the drawbacks, these are the technical challenges we face, but it's not the end of the story. I see another case, another similar young patient with a similar medial sphenoid ring meningioma. Again, you can see this is the intraoperative video of this patient. You can see it's a very firm tumor. This is the microcissa I was talking about. This was the only microcissa I had, and you can see it's not cutting. It's not sharp enough, right? See, this is the carotid artery here, right? So you have to be very, very patient, right? So these are technically challenging cases, right? Especially when you're working under difficult circumstances. You can see the middle cerebral artery here and the anterior cerebral artery. So you can see after dissection, these are the vessels I have preserved, and I have done a complete resection. So this is the post-operative CT in 24 hours. You can see this is the contrast CT. So I have taken out the whole the tumor out, and the patient presented with ptosis, and her ptosis she's completely asymptomatic now, and her ptosis is completely resolved today. This is another case. You can see it's a recurrent. This is a third time recurrent medial sphenoid wing meningioma, and this is a very challenging case in an old patient. You can see, and I had to leave a sliver of tumor which is attached to the carotid artery in this case. So you need to learn when to stop, right? You need to learn your limitations, the restrictions and the limitations as you gain experience. So it's not always taking the whole tumor out. It's always thinking about the patient's outcome, and it's always removing as much as possible, giving the patients a better or a safer outcome. Right. So these are few scenarios I'm going to show you where you need to think, where you need to depend on your clinical skills and the clinical decision making. So this patient is a 78-year-old lady. You can see this is a non-contrast CT, right? This is not even a contrast CT. So she presented with this tumor and severe headache and intractable seizures. So nobody was willing to operate on this patient because they couldn't do a contrast study even because she had multiple allergies and she had renal impairment. So we could not do an MRI. We could do a CCT. And at that time, MRI was not available in my hospital as well. So this is what I did. So this is the post-operative CT, right? This is the post-operative CT, but this is what I did. So I did this surgery through a mini craniotomy. It's an eyebrow incision. And even without the imaging, because you can see the lesion. You can see most probably it's a meningioma. So, but you can see here, to our surprise, this is what we saw. Once we removed the tumor at the base, I found this aneurysm, right? So it was a meningioma plus an aneurysm at the skull base. So this explains you that you can see the hypodensity here. So she must have had a bleed, aneurysmal bleed, few years back, even though she could not recall it. And that's the reason for the hypodensity, apart from this lesion. But I was fortunate enough to deal with this complex case, even without, the prerequisites, such as even a CT angiogram or an MRI, right? But she was headache free after after the surgery, and she was very, very happy, and she did very well. Another scenario, you can see, I'm sure you can see the small lesion here. This is a patient with polycystic kidney disease, and this is a vascular malformation. And this patient had repeated bleeding, and he had refractory epilepsy. Again, this patient had multiple medical problems, and the anesthesiologist was not very keen to operate him under general anesthesia. So I operated this patient with a very small incision, with a little bit of sedation, right? So you can see this is the lesion there. So obviously I had no the navigator at that time. So I had to basically depend on the craniometric points, and this is what we did. So you can see I made a very small incision. My challenge was to find out the sulcus, right, to get into that lesion, but I was able to do that with the aid of the anatomical landmarks and the craniometric points, and this is what we did. So this was the vascular malformation, and we removed it. So you can see the preoperative CT here. You can see the lesion here, and see the postoperative CT here. You can see it's a very, very small the mini craniotomy, and you can see the lesion is gone, and the patient was fever free, and you can see the incision. It's a very small incision. This is the patient. He did really well. Few cases of minimal access meningioma accession when the patient was a bit frail, right? So these patients had refractory epilepsy, but these patients had multiple comorbidities. So I operated this patient with a very small incision. But remember, when you start your career, you might not be able to do these type of, things, because it takes some time, right? You need to gain the experience, and it takes some time for you to get on with this type of procedures, right, in your career. So you can see it's a very small incision. You can see here as well, it's a very small incision I have made. Here also, it's a very small incision. So very quickly, we have done the surgery without compromising the patient, right? Complicated cases, right? This was deemed inoperable by a few people elsewhere, and this patient, 75-year-old patient, came to me with this recurrent large meningioma in the posterior fossa, infiltrating the sinuses as well. So even though this was the least equipped and the neurosurgical center with least facilities, I performed this procedure 2 years back with the reconstruction of the sinuses. You can see here, with the basic facilities we had at that time. And this is the post-operative MRI. You can see almost we have done a gross total resection of this patient, right? So this is the pre-op, and you can see this is the post-op, right? And this patient did very well. Another case, maybe the last scenario, a recurrent glioma, a recurrent GBM in a young patient, right, in the dominant hemisphere. This was done initially with brain mapping and all, but this patient presented to me because nobody was willing to operate in this patient because of the poor prognosis, right, and the involvement of the speech area. And I did this. I didn't have facilities to do brain mapping, but I did awake craniotomy completely under local anesthesia. Patient was completely awake throughout the procedure. And this is what we did. So we did the gross total resection of the tumor. And this is him after 6 months. So this is after 6 months. There was no recurrence. And he only had very mild speech disturbance. Apart from that, he was very well. So it's not all about technology, right? It's always, remember, think about the possibilities, right? Think about what you can offer the patient safely, achieving the better outcome, right? So finally, remember, simple may not be always simple, right? This is a straightforward case of a meningioma. I want to show this patient. She's a very obese patient. The removal of the meningioma was straightforward, but remember, I'm this the point I'm always stressing you. Neurosurgery is actually a multidisciplinary team management, right? You need the help of your nurses, right? Everyone in the wards post-operatively. It's not always about only the neurosurgeon. It's a teamwork. So it was a straightforward removal of a meningioma, but remember, but see, she developed meningitis after 5 days. Her wound got infected, right? This patient developed meningitis, and this patient was bedridden for years and years after this simple procedure, mainly because her incision was initially got a superficial infection and then it spread. We had to remove the bone flap, but she developed meningitis and ultimately she was bedbound and she was quadriplegic for a longer time. So in conclusion, right, as neurosurgery aspirants, I have few messages, take-home messages for you. Thorough knowledge in anatomy and function is mandatory for any neurosurgeon, right? Especially for a beginner. And you need to be a skilled surgeon, but remember, number one is safe surgeon, safe and skilled surgeon with sound exposure, with correct attitudes to a patient. Remember, patients are the most important aspect in your life, right? And patients are key. And remember, patient outcome is the most important aspect in your life. So look for safe and effective alternatives and or innovations without violating the principles always. Always follow the principles. And if you don't have the facilities, don't lose your heart. Look for innovations, look for alternatives, do the best you can provide to the patients at the correct time with the correct attitude, right? So I hope this must have given you some inspiration, right? You must have learned something, and you might remember this and use these tips and from what I learned, and it will be useful for you in your future career as neurosurgeons. Thank you very much for the opportunity.
Thank you very much, Dr. Surat Mansinghe, for that excellent presentation. Anyone has any questions? Any comments on that?
Hello, Atta, are you there?
Yeah.
Are you there, Atta? I don't know if he's a neurosurgeon from Switzerland or anybody else, Simon, Medina. Any comments or questions? Well, go ahead, Atta.
Yeah, excellent share, excellent presentation. And I can understand very well the way you face through these challenges because I shared the same experiences. I congratulate you for making it to Colombo now, and we would expect more from you in future. Thank you.
Thank you very much. Thank you for the comment.
Yeah, I'm not a neurosurgeon, but I can see you are in from some nail-biting moments, waiting, operating without our CT. Originally, neurosurgeons didn't have CTs. Imagine back in those days, they had to make do without any machinery. But I think the good news is that with the increase in technology, I think there'll be devices that pretty well take the place of CT. Now, ultrasound, I know that, do you have much experience with ultrasound of the brain at all? I think that's supposed to be affecting some areas of diagnosis. Have you ever tried ultrasound?
Yes.
Not much in my cases, but ultrasound is it's very handy in sometimes it's very handy in tumors and all, you can locate. So it's a very good adjunctive tool in
Interesting,
neurosurgery.
Dr. Surat, this ultrasound somehow have not been exploited for the good of
That's right.
low resource setups. We
Mm.
remember this GE had a Sonovant as one of the options, but it did not take off for some reason because the monetary benefits were less. So the Norwegian group has done a lot of work, and I was fortunate that during my training in training period and afterwards, I used to utilize ultrasound for in your navigation, and it's a standard gold standard for real-time navigation. So, but
That's right.
I totally agree with your approach that the basic techniques, the basic skill and principles, they are more important than these gadgets which are ever changing. So these are something which could be utilized in resource limited setups. I just like to have your comments on your endovascular experiences in Colombo, endovascular
Yeah.
neurosurgery.
Yeah. So we do have neuroradiologists there, and so they do perform these endovascular procedures, coiling, flow diverters, they do. But sometimes, it's mainly when it comes to, the cost, the cost benefit. Sometimes it's not always possible to go for endovascular procedures. So things are the cases like basilated aneurysms and sometimes even giant aneurysms. So they do these endovascular procedures, but some neurosurgeons, they prefer endovascular procedures over the microscopic procedures. But in my case, I prefer whenever it's amenable, considering all the factors. If it is amenable and if it is safe for the if it's safe for the patient, I usually prefer the microvascular rather than endovascular. But it depends on the surgeon. So we in Colombo, so we have the facility of endovascular procedures as well. So it all depends on the risk benefit analysis. So, but in my cases, as a neurosurgeon who is more keen on neurovascular procedures, I go for microvascular, but sometimes depending on the situation, we use endovascular procedures as well. But it's not freely available in peripheries, right? So it's mainly in Colombo and Kandy and in Gaul. In other peripheral centers, they do not have endovascular procedures. So they send most of the patients to Colombo, or they are more concerned and keen on the microvascular procedures.
Thanks.
Very good. Thank you. Okay, I guess we'll move on to the next speaker. Thank you very much, Sarath. I'll be sending you information about speaking at the Skull Based on the 18th and 19th. And once again, very good. Thank you. Okay.
Thanks.
Very good. Rohan, could you please introduce Bhushan, please? Rohan?
So Professor Bhushan, okay, yeah.
Yeah,
So
could you please
Professor
introduce
Bhushan
the next?
Thombre,
Yeah, okay.
yes. Professor Bhushan Thombre did his MBBS from GMC Nagpur, India. Following it, he did at Topiwala NAR TNMC, MS surgery, and he did his neurosciences, MCH neurosurgery in Nimhans. Currently, he is a clinical fellow spine at University of Toronto in Canada, and also has an experience of 20 years as a consultant neurosurgeon as well as assistant professor at Mahatma Gandhi Institute of Medical Sciences at MGM. So, Professor Bhushan Thomre, we welcome you, and the floor is yours.
Hello, am I audible, Rohan?
Yes, can't see your screen.
Yeah, sorry, my computer just crashed.
Oh,
I'm not at my place. I will require like 2-3 minutes just to
okay,
boot it up. Yeah.
okay. This is like neurosurgery. You never know what's going to happen.
Exactly. I was planning to have like a light day today, but I had to run into an emergency, and now I don't have my laptop, so I'm just presenting from some
Yeah, okay.
desktops
So
available
we'll
here. Yeah.
just do the best you can.
Yeah.
You know, if you want, Bhushan, you can send me the PowerPoint. I can present it.
Yeah, that will also be a good option.
You can send it by LinkedIn, the file, the PowerPoint file, and I can screen share.
Yeah, I think that will be a good option.
Yeah.
Okay.
Okay, I'm going to LinkedIn now. And I'm going to your LinkedIn profile.
I got it. Okay. Is it visible now?
Yes. Yeah, can you make it full screen?
Yeah.
Yeah, perfect, perfect.
Okay. So today we'll be talking about empowering the next generation of neurosurgeons and how AI can help it. And I will also try to share some of the resources which can be used by our young neurosurgeons, whether they are preparing for their exams or they are in their residencies or trying to do something in the research. I will try to be as comprehensive as possible. If you got any questions in between, please raise your hands and stop me in between so that we can discuss it at that time too. So now going forward, so today we'll be discussing what are the currently available tools, what are the AI tools you can use to better prepare your exams, and later on how you can use it to train yourself better during the surgery. What are the limitations of the use and what things you should be careful about while using such tools, because there are a lot of things which can go wrong if you're not careful and know the limitations of how you are using them. Because uh, hammer, you can do a lot of good things with it, but if you use it wrong, it can do a lot of harm too. So you need to be careful while using these powerful tools. Okay. Uh, First of all, we will understand how currently the neurosurgeons use social media as well as some kind of tools or the technology, how they use it, apart from what we use in OR. Like globally, nearly 78% of the institutions, neurosurgeons have some kind of social media exposure in terms of YouTube, Twitter, Facebook, or whatever. And if you are non-academician, the rates go a little bit higher, particularly in countries like India, where 88% of the professional can use WhatsApp, YouTube, and Instagram to showcase their work and go forward. So it's much higher than the global average, as you can see, from 65 to 88%. It's a good thing because uh, you have to work with what you have. But with the advent of AI, there are a lot of tools which you can use with just a computer and your mobile phone, and you can gain access to a lot of things in terms of research as well as your education to uplift yourself from what you're doing. So as you can see, as a modern neurosurgeon, many won't disagree that you should use AI tools, but many of them don't use it on daily basis, or are not confident enough how to use them, or uh, are not using them efficiently as they should to advance themselves. So I will try to cover some of the basic stuffs, and then we'll go to some of the advanced stuff which you can use during your trainings. So this is one of the studies, like if you go through a PubMed, and I have developed one software where you can do all kind of searches just by giving single search. Not only like you get, let's say, a 10 or 20 page research articles at a time, but you can get thousands of them in a single go. As you can see, like this is called as a PubMed article downloader, and you can just put some kind of mesh words or whatever authors, and it gives you a lot of results in terms of such excels, as you can see on the right, with all the affiliations, authors, and all. So I developed this tool and downloaded like how this AI and machine learning is evolving, and you can see like currently there are like 8 to 10,000 articles. And if you go for a simple distribution, descriptive analysis, you can see majority of them are from China, Germany, Canada, and very few are from India, like just 5.5%. Although the tools available are exactly the same, because uh, the tools required are very minimal in terms of like a computer, a mobile phone, and you are just good to go with the top end technologies which are available throughout. You just need to know them how to use it, and to know them how to use them efficiently. So after the talk with Dr. Mr. Surat, where he described a lot of basic steps, we'll now go to the advanced stuff, how you can utilize technology here. If you want to understand some basics of how the AI works, I have done one presentation with Dr. John before, where I have described all the various algorithms, how you can use it and how to understand them. And it might be beneficial if you want to go that route and try to understand what basic algorithms and how to utilize them and how to train them basically. So we will go to the summary first for this lecture. So that you get a grasp of what we are gonna go ahead, and how you can memorize it faster. Like if you're in medical schools, you can use AI for note summarization, research assistant, with the help of commonly used tools like ChatGPT, Notion AI. If you're a resident, you can use it for surgical simulator and improving your performance, like with touch neurosurgery, neurotech via simulators. If you want to do some, let's say, research projects, you can use programming languages like Python, R, and other to build up your predictive modeling and data analysis tools. If you are in your early practice, you can use like imaging analysis, report generation, particularly in cases like where we are very resource limited, like let's say in Sri Lanka as well as in rural India. You can use these tools for analyzing the images to get the reports earlier, so that even if there are no radiologists, no neuropathologists are available, you can get your reports there and there itself. So you can use them to connect with your global colleagues, so that you can share your research and use translating tools, which are really at a different level today. So some of the must-use tools for your career planning, like if you are still not sure about how, I will go through the different stages from, let's say, whether you're deciding how to go into neurosurgery, and then step by step how you can go it and use it. So if you're still not sure, you can like ask AI about what are the different interests are there, or different kind of neurosurgery or different kind of surgical branches for that matter, whether you're not sure whether you want to go to the medicine route or through a surgery route. You can discuss with just like a person. And I'm sure about like current 4.5 and other models with ChatGPT and other good LLMs are so knowledge efficient that they will be able to give you enough information to make such kind of decisions, rather than going to different neurosurgeons. Of course, that's the ultimate thing you can do at the end. But if you want to just screen around, you can go and ask questions like whether what actually the functional neurosurgery is, what people do in vascular neurosurgery. Because in the early phases, when you are not sure what branch you're gonna choose, this kind of questions are very basic, and you might feel like I was an introvert person and it was very difficult for me to ask people about such questions. So if such tools would have like at that time, I would have like been much a better position to make a decision early on in my career to focus my energy. Also, there are like a lot of chatbots where you want to tailor your applications for your medical schools, or for your directors at medical school, or for any interview you want to prepare any questions. You can use such kind of tool. And definitely for research, you can do this tool. We will go into details one by one in each of them. First of all, like what tools are available and how you are going to use it pragmatically, we will discuss today. So there are a lot of junk tools available and a lot of good tools available throughout the AI space today. There is quite a lot of bubble around it, and you have to know which kind of things you can use and rely upon, so that you are not steered into a wrong directions. Choose any good LLM from like OpenAI, or from DeepSeek, or from Microsoft, or Gemini from Google, and just stick with it throughout your learning protocol, so that you get to know the consistency and you know the limitations of that LLM. Because as any human, or as any person, every tool has its limitations, and you should know, and you will only be aware about it limitations once you use it regularly. So if you use ChatGPT, just stick with that. If you use Perplexity, just stick with that. If you use Gemini, just stick with that. And over a period of time, you will know where you can utilize it, or you can rely on those responses, and you will know when you don't rely, where you can't rely on those responses. Because still, although the problems of hallucination and all are decreasing day by day with such tools, but still they hallucinate, or sometimes the base data may not be the base data for you. What I mean by that, like uh, if they are too good for you, it might not be providing information what you are asking for, and you have to tailor your questions accordingly to get most out of those tools. And every tool has a different type of questions, or you can say the prompt engineering, what they required, so that you know about what questions to ask and in what way you can ask them the question. So in general, I use ChatGPT or Perplexity or Gemini, and you are good to go. Okay. So the most commonly used tool, ChatGPT. everybody must know it, and if you don't, I will like encourage you to start using it. You can simply go to chatgpt.com and get registered and start using this. Currently, it's a version ChatGPT 5, which just recently launched. There are paid as well as free version. I encourage you to start with the free version first so that you are familiar with it. One thing I would like to encourage you doing is like if you are like asking some kind of patient information or sharing some kind of data with it, which you don't want them to use it for further training, you can just go to the data control tabs in all of these apps, like in the DeepSeek as well as in ChatGPT. They have tabs like if you go to data controls and you can turn off the improve the model for everyone so that your data is like little bit more secure than what it rather than freely for them to be utilized for the next steps. Basics, like you can just go ask them the question and you can ask something like whether I want what kind of surgery neurosurgeon perform, what kind of salaries they get, what kind of work they can get to do, how much are the working hours, and all such kind of basic stuffs, and you're pretty good to go as a neurosurgical aspirant, whether to start with a neurosurgical journey or not. So it's pretty helpful for you if you are not sure to. Then you can go into deep things, like if you want to do some kind of research and want to know some kind of statistics, you can go into an uh, activate the research tab, like a deep research and all, and you can ask it questions like historical development of certain tools or historical development of Indian neurosurgeons, and it will give you all kind of descriptions like how the Indian neurosurgery was there in the beginning in 1940s, 1950, 1960, and everything, and over a period of time how it evolved, and it will give you a lot of details. And it will be like it will save you like tons of time. A week of research can be done in just 15 minutes, and it's like very deep kind of research which you can discuss and read about it. You can go into higher ends like quantum computing in neurosurgery if you are familiar with and interested in some kind of technical steps to do in the future. So if you are a researcher and once you have now, we will come to a period like you have decided that you want to do neurosurgery now, or you want to become a surgeon, and now you want to build up your profile by means of doing research or by means of doing some kind of projects with your seniors, and you want to do some kind of literature search, you can go to the chat GPTs. There are some specified tailored models available on the chat GPT, or other kind of models like OpenLLM, Llama, everything is there. And but I think for if you are just starting out, these models are very chat GPT is very handy to use. You can use models like SciPace, Scholar AI, Consensus, and it will give you questions like if you want to read about robotic surgery, you can ask it and it will give you like 10, 20, 30 papers about it, and you can go through it and be interested and about it and read about it. So there are a lot of things which you can do just by using these tools. And once you find some kind of basic research questions, you can contact and connect with other neurosurgeons or anybody who is practicing, so that you can build up your research portfolio, which will help you later in the applications as well as your future, so that you're good to go once if somebody asks you like what kind of research are you interested in, what you have done, so you're good to go from that standpoint. I will like show you some kind of analysis here. Uh, so if you have like starting some kind of research and want to just one.
Did we lose the audio?
Yes, the audio is not audible.
Oh, okay.
Is it audible now?
Yeah, I can hear you now.
Okay, fine. Okay, I will go ahead. So
It is audible now.
once once you have like formed a research question, something like on the brain stroke, and you want you have found your questions and you want to build a study based on that now, and at the end you will get a worksheet where you have analyzed like gender, age, hypertension, other diseases, and residency type, glucose, smoking, and the output or the target variable is stroke, and now you want to analyze it. You can use it, you can do it with the help of ChatGPT. Here, like let's say like it will analyze the age, the counts, and BMI for you. And not only that, it will give you some kind of descriptive analysis, like how much female, how much male were there, when married, a residency status, the smoking status, and then you can ask it to analyze it for you so that you get an idea what kind of research or what kind of statistics you can apply on that kind of available data. And you can draw different kind of plots. You can do some kind of predictive modeling, how is the behavior of a stroke in a seniors greater than 60, less than 60, different across different BMI categories, and you like a different age distribution.
Sorry, please check the audio again.
Yeah, it's probably the connection. I guess it's Bushan. I guess it's the connection is not working too good. Can you hear me, Bushan? Because we can't hear you now. Oh, I think you may have dropped off. Well, just hang on there. Bushan, are you there? I'm screen sharing. Oh, you can hear me, Bushan. Okay. We can't hear you yet, Bushan. And your camera's off. Let's see here.
He's
Please.
asking adding to the panelist again.
Yeah, let me check. Okay, yeah. Okay. Coming in, Bushan. I'm trying to promote you. Yeah, I'm promoting you, Bushan. From that computer
Yeah,
device.
am I audible now?
There you go.
Okay. Yeah, something going on. Sorry for that.
Okay.
Okay. When did I lost you? Did you hear about this charts?
Not yet.
Okay,
From the
fine.
data visualization.
Data visualization. Okay.
Well, that's good, Rohan. You're paying attention.
Thanks for that. So, okay. You can do data visualization like for age, glucose, and stroke distribution. And I will always advise you to recheck it. Nowadays, they are pretty good to go as much as I am concerned. But if you want to do some kind of complicated analysis, you can get advice about how you can do it, and do it on your own rather than relying on the chat GPT to do it. Okay, but definitely you can do it. Just you need to check and recheck it. As you can see here, you can do one-to-one analysis for like residency type, whether they are smoking or not smoking, and how was the how whether there was a stroke, in how they behaved in such kind of patients, how was the gender analysis and all. And you can also do some kind of segregated analysis and get a correlation between BMI versus stroke, and to check how effective those parameters are there based on their own, rather than like multivariate analysis you can do on such kind of parameters. So it's a pretty nice tool, which is very handy and will reduce your research time from months to weeks, for that matter. And only like some kind of data collection part you have to focus on, and can help you writing your stuff and all later on. So that's a pretty good tool if you know how to use it properly. So there is another tool like data analyst, another chat GPT, which you can use, which will help you do the things which I have shown you now. Now, another tool is Notebook LM. It is like very essential for preparing for your exams, very essential for preparing your for your guides or for revisions, and it's a very what do you say, important tool if you know how to use it properly. All my tabs got closed. Sorry, Dr. John. I will take a
Okay.
minute on him. So let's say you want to read and understand and study on the topic of a cerebrospinal fluid leaks, and you want to understand how to diagnose them, how to manage them, how the patient experience was there before. You can go to the notebooklm.google.com. It's a tool where you can uh, put your research notes, like as I have done on the left side. You can put your papers, you can put your website links, you can put your books all together here, and you can ask this chat about your specific questions you are interested in. You can ask him to produce multiple choice questions for you, so that you can be tested against that knowledge what you have just put it or you have read about it. The funny thing is, you can like do some kind of mind maps like this, so that it will help you revise better, like types of CSF leak, the causes of CSF leak, different kind of diagnosis, how they are treated, what kind of imagings can be done for such kind of CSF leak, like MRI, CSF cysternograph, what treatments are available. And I'm telling you, like it will reduce your revision time so in like half, and so it's like really important tool. This is the mind map tool, and sometimes you don't have available uh, uh, tools with you. Let's say you don't have a available PC with you, and you just have a phone, and you can ask him to produce a audio overview of everything for you. And once that audio is generated, you can while traveling or you're going to your classes, you can just hear them out, and it will help you remember all the information throughout your day. So for your exam preparations, this Notebook LM is a pretty good tool if you want to revise and go forward from there. So I will really encourage you to use this tool for your preparation. Another things which you can use, although they are not so strong currently, are video generation tool. You can use it for, let's say, you have project something based on your community analysis, or research involves speaking to a lot of people and you don't have a time to speak with them, you can produce some kind of a small videos which will explain them what you're trying to do, and so that your time is more focused on your research rather than trying to explain the same thing to your research group or patients every time again and again. I won't go into much details. You can produce such kind of templates also. You must be aware of it. And although they are not perfect, but they will do the job of informing it in like different languages, different scenarios for different people. And you can have added information while giving to such kind of patients. So this is one of the video. I'm not gonna play it, but you can produce and give such kind of prompts. Like if you want, if you're doing some kind of research where you want to raise a helmet awareness, you can give such kind of prompts, and the video will be generated for you. The second important tool, which is important for people where there is not the problem is in literacy, you need to come up with innovative solutions like audio generation, so that the same things can be done with audio, and you can do it in different languages. You can do it in different thoughts, different accents with the help of tools like this 11labs.io, where you can go and paste your script, and let's say you have some kind of research questions and you want to explain the consent or some kind of information which is going to be repetitive for your, let's say, hundreds or 80 patients which you are planning to include in your research. You can just send them this kind of audio files so that they can listen or play them before you go and speak with them and answer the most common questions which they are planning to. And it need not be in just English. You can use all kinds of languages: Malayalam, Kannada, Marathi, Hindi, and whatever regional languages you are planning to. You just need to write a script in English, and everything can be translated, and you can choose the accent in which it can be spoken, so that the local dialect is also taken care of. So it's a pretty amazing and powerful tool if you know how to use it and where to use it. It can save your hours of time if you are planning to do research in such kind of things. So similarly, as you can see, it's done in Hindi. You can do all kinds of languages. Now, let's say you have like collected such kind of research and you want to now analyze it, not only the text data, but something of an advanced kind, like let's say image segmentation or classification. You can use a lot of tools like TensorFlow for image segmentation or Neptune AI Blog, which are a little bit easier to use, but everything will at least include some steps. Like let's say you want to analyze the post of x-rays of spine, or you want to analyze the post of or how the pre-op and post of chest complications are behaving. You can use such kind of tools, and you just need a PC and a mobile phone to capture the images, and like there are no limitations how much you can do with such basic tools which are there in your hands. Like you need to just collect images or videos and then do the data preparation, image annotation, labeling, which will take maximum amount of your time during the research. Let's say like if you have 100 images and you want to do annotation, it generally takes me around a week or so to do it properly, depending on how complicated they are. And after that, you can train your models, and you can include that to produce outputs for your newer images or newer classification systems, and you can do a lot of research. It's a little bit complicated than what we have shown before, but it's definitely doable. You can use, like if you are want to learn programming, I have something coming up with Dr. John, and we can talk about it, but you can do it pretty much on yourself too. With TensorFlow image segmentation, you can do. If you don't want to go into the let's say programming, and you just want to do some kind of visual programming where you need to arrange and do all the steps, you can use something called as a Neptune AI and do kind of image segmentation. There are a lot of tools available beside that, but this is where I think the balance can be found. So such kind of things can be done. I will show you some kind of applications for such kind of image segmentation, so that you get an idea of what kind of research projects you can think about while doing. So definitely you need to be very careful, like don't enter patient's data, uh, and as I told you, don't use it to share it. Use your local servers if you are planning to use your research data for it. Now coming to actual, like now you are coming to the next step. You have chosen your neurosurgery, you have chosen how to do your research, you have applied your application CV, and now you want to basically train. You are a resident or something and you want to train yourself. So definitely there are a lot of simulators available. Although many newer simulators are have integrating AI into it, some kind of augmentation with visually as well as tactically, but most major bulk load is with microscope and visualization. So I am compelled to include this into my talk. You can use such kind of microscope and dissecting simulators where it will help you, like let's say if you want to train about how to clip an aneurysm, how to dissect a sylvian fissure, how to analyze or identify various like identifying, I'm telling you, like identifying inferior let's say inferior frontal gyrus and various parts like pars opercularis and pars triangularis on a whole skull is very much easier rather than just going perennially and trying to identify such kind of structure. So with such kind of simulators you can help and get trained yourself to identify not only the normal blood structure but get simulated, or like here the person is trying to clip an aneurysm and see aneurysms in this matter, and going from here and dissecting the sylvian fissure. So you can, if you get a hold about it somewhere in some institutions, some universities, you can go there and practice yourself and get trained on it. Similarly, there are some simulators which will help you, like not only in microscopically but hands-on. Like here, somebody is trying to suture the dura, so that you know while actually doing it, and you are more prepared during your first and second surgeries, so that you are more confident while doing such kind of procedures into your future. These are more advanced augmented reality kind of analysis, where you are not only getting tactical feedback but as well as visual stimulations, and there will be scenarios where there will be bleeding, there will be injury to the MCA, injury to the ICA, and you have to manage it in real time. And those are pretty complex and very rare to get hands on, but if you can get them, there is nothing like that, and you will be much confident in your surgical skills once you start operating on that kind of things. As we have seen before, the vascular cases might be very rare to come into your practice in the beginning, and the complicated cases will be much lesser. So such kind of advanced simulators can help you build your confidence when you are not operating them frequently. So I will definitely advise you to go ahead and try to use them. Then comes some kind of cadaveric courses, like here placenta. If you are planning to go into vascular neurosurgery, you can do some kind of simulations and anastomosis, various kind, end to end, end to side on this placental, as well as other cadaveric courses are there available where you can like go and just join them. And I don't think anybody will stop you, even if you are not a neurosurgeon, to attend such kind of cadaveric courses, because everybody will be welcoming, I'm sure about it. So if you get a small lab, you can do it in your home university also, because placentas are available very frequently. If not, you can go and find some animal tissue for you and start practicing your vascular skills or microsuturing skills on such kind of cadavers. There are some online resources available if you want to get trained and more familiar with the neuroanatomy. There are very good courses from Stanford Medicine as well as other universities like U of T. Also, where you can go and assign, some courses are paid, some courses are free, and you can go and analyze some uh, uh, 3D models there. As you can see on the right side, you can see CT angiogram reconstruction, and you can see the aneurysms. You can see how they change the normal anatomy from the abnormal one, and you can get trained yourself. Here you can see the courses of temporal arteries, so that you can treat vascular diseases like moema and all, and you become more confident in that. Also, there are courses which will teach you about let's say dissections of white matter. I have done a lot of white matter dissections. If anybody is interested, I can be happy to share the resources with them, some kind of articles where to start and how to start with white matter dissection, so that they can be more confident while dissecting on tissues like glioma and all other kinds of things. There is a very good resources, particularly for spine. I will advise you to go to this aims.net, where they have like lot of cadaver. They perform regular cadaveric courses. If you have time, you can go and visit there and get trained under various kind of things. They have lab open like 24 throughout the year, and you can go and apply for 5 days or 7 days, and you can get trained for vascular courses, simulations on the rat, anastomosis, and all. They have a pretty good lab. If you want, you can go there and spend some time. Coming to the end of now, you can use your skills in AI not only in diagnosis, radionomics, decision making, pre-surgical planning, but on surgical workflow like patient's behavior, administrative talk, follow-ups, and recent publication summarization. Like you can analyze tens of thousands of papers and just get the summary of it with the help of this kind of AI. So just be there. I will show some examples. Some of these is my research. Some of these are done by other persons. Here you can see the diagnosis and radionomics, how they have used and done some fractal analysis around the tumor tissue. And you can use it today. You don't need anything fancy. You just need a good laptop or good machine and some kind of information and read about it, and you can do it. You don't need much kind of technology today, just simple stuff, and you can do such kind of things. So as you can see, the fractal analysis on the right side is so nice, later over the tumor. Similarly, you can do imaging genomics. Like if you have MRI available, you can predict the histological mutants like IDH mutation with the accuracy as good as 0.96. That's as good as it can get. You can do MGMT, H3K, 27 mutations just by doing imaging rather than having to wait for a histopathology. And you can do such kind of projects too if you have available resources with you. There is a tool like this, glioblastoma predictors. You can use them to analyze and how to tell about how your patients are going to progress over the period of time. Similarly, segmentation, meningioma, differentials, everything you can use today. Similarly, in traumatic brain injury, there are different scales, some unsupervised learning scales. You can go to the basic understanding course, which I have mentioned before, to understand how the supervised and unsupervised machine learning works, and you can understand how the segmentation and the prognosis can do better sometimes, just rather than just using GCS in your scaling. This is one of my projects which I did during my residency, where I the frozen and squash report I was able to get within like 4 to 5 minutes, and it has been published, and I got an innovative award from the WFNS Society for such projects, where like if you insert such images into the microscope, within like 2 to 3 minutes you get your reports in the intraoperative section, and you can do it multiple times, and the accuracy is as good as a neuropathologist. Similarly, you can there are newer techniques, as a recently published paper in Nature, like Raman microscopy, and you can get histology kind of accuracy with such kind of papers. So this is one of the imaging analysis. Like many a times you are not sure what kind of implants are there during the surgery. You can do a simple X-ray and then upload this to this tool, and it will tell you what kind of screws are there, what kind of models they have used, so that if you are planning to re-explore such patients, you know what implants you are expecting. So one of the practical problems which are faced by many of the neurosurgeons when they operate on revision surgeries which has been operated outside their jurisdictions or outside their uh, uh, patients group, whose implants you don't know what they have used. There are adult tools like vestibular schwannoma neuro GPTX. If you want to discuss about let's say vestibular schwannoma, this is your go-to tool for such kind of thing. This is another tool where like you can ask such kind of schwannoma questions and you can get your answers. So in non-surgical workflow for your bed allotment, you need not be just a neurosurgeon to use it, but it can efficiently make help in your workflow management of the bed allotment, staff management, patient workflow management. They're managing their follow-ups, and it can help you a lot during that time. So, but there are some downsides which you should be aware about, like direct disadvantages. You can get into inadequate training. You can feel like poor understanding of the basics if you just rely on such tools. You should understand the basic first and then start using these tools so that you know where it can go wrong, where it can go right. You can make more surgical errors if you just use such tools rather than getting actual practice in simulators and all kind of things. You should know what is contextualization and where these tools can be applied, because these tools most of the times are not generalized. They will work only in that specific scenario. Indirect disadvantages include like you can feel de-skilling. There will be overconfidence if somebody is speaking about just based on the AI. Definitely it can go wrong, and if you don't know its limitations, you can become overconfident about your uh, uh, results or your predictions, and and if you are not aware about the limitations, it can help derail your outputs. Similarly, automated workflow biases are there, race, gender biases are there, and you should be aware. That's why I was telling in the beginning, you stick to one tool and try to use it repeatedly so that you know the limitations of that tool, you know the biases of that tool, where it's overfitting, where it's overemphasizing the thing, where it is underemphasizing the thing, so that you can compensate for that in your mind once you start using that tools in a real practice. So you should know the statistics, then you should come to the machine learning, artificial intelligence, and deep learning, because otherwise it's the mother of everything. So that's one of the output from this. You should. And I would be happy to get connected with all the aspirants. If they have any questions about it, if they want to get involved in the research, they can connect with me. I'm trying to build some thing over which we can build and have some research projects. If anybody is interested, can connect. Thank you.
Okay, go ahead, Rohan.
That was a excellent presentation. I also saw your video, which you had prepared 2 years back, I think, on the same topic. But yeah, it is. I think is there anything updated in this or
Oh, so yeah, which one you saw, Ron?
on
Yeah,
YouTube?
I did
I
lot of things in the last 2-3 years.
okay. Okay. So yeah, I would like to get connected for the research part. I am
Yeah,
also into the machine learning modeling and those kind of things.
yeah,
Deep learning AI. As you said, statistics, very core component of it. So maybe yes, I should focus more on I can take your help in building my statistics more and then go ahead.
of course, Ron. Anytime you can connect with me, no problem.
Yeah, great presentation, Bhushan. You know, Ray, I want to show you a problem. Actually, it's a real life consultation with the application of AI in a neurosurgical scenario. And let me share what I'm talking about. Uh, right now, okay, these are modules that you can see. They're modules of education and neurosurgery that I propose that is applied to world neurosurgery education. Okay, and basically, I'm trying to align with a big university in the United States. And let me describe the problem. Or it's not a problem, it's a challenge. Okay, that's what you call problems in neurosurgery. You don't call them a problem, you call them a challenge. So these are the modules. Okay, say I'm aligning with Barrows in Arizona, probably one of the best neurosurgery programs in the world, and neurosurgery education also. Okay, I'm trying to get them to sponsor basically uh, a channel they call Mission Brain. Okay, and basically I'm approaching them saying that, wait a minute, we need a structured curriculum to present to developing countries. Okay, and I think we can do that with the cooperation of AI. The way that I think it can work, and you can tell me with the background that you have in AI, is that basically Barrows in Arizona has a huge population of residents that have worked there, fellows that have worked there, people that have visited there. And so what that gives you is a fixed data set. And from what I understand about AI, they can analyze that fixed data set so that these modules amongst the data set of Barrows alumni, you can go through that fixed data set and determine which of the people are good in neuroanatomy and neurophysiology, which of their alumni are dealing in new tech or have given lectures, or any of the alumni that have a background in neuroimaging, and go to them and say, do you want to give a lecture in your area of expertise? Do you think that would be workable in this challenge, Bhushan?
Uh, yeah, I think that's a pretty nice idea. Uh, uh, yeah, of course. I think it can work. It can work.
Yeah, I'm gonna talk to you maybe after the show and tell you exactly more details of what's developing. But I think really the key now today to establishing a workable global neurosurgery channel, which we want to reach countries like Sri Lanka and India with the latest technological developments. And I think AI is going to do it. And I'll explain to you after the show the way we're going to approach academic institutes to get some kind of collaboration going. because as you know, online neurosurgery education is very fragmented, disorganized. It's all over the place. You get a skull-based conference, you'll get a tumor conference, one conference, but you really need to have a consistent daily, almost daily education in neurosurgery for the developing world to give them access to areas of expertise. But anyways, well, we can talk about that later. Okay, that's it for me there, and I appreciate. I mean, to me, I love this. The problem is neurosurgeons don't have much time, and of course, you can't ask a neurosurgeon, okay, learn Python. Do you know now? Do you know Python, Bhushan?
Oh yeah, of course.
Well,
I do.
yeah. Well, neurosurgeons, they don't have time to study
True.
Python, which of course would be the optimum situation. And this for me, I'm going to try to learn Python because I'm not a neurosurgeon. I don't go to the OR, and so I have time. And I don't know how you carve the time out, but learning Python, then I think you can really do things. You can create things in neurosurgery. You can create programs, et cetera, et cetera. But we've got to find a way that neurosurgeons can avoid having to learn a lot of that and give them easier ways to get benefits from it. So
I agree.
anyways, we can talk later. And I appreciate you spending the time, Rohan. I appreciate the time you carved out. And stick around for a couple of minutes, Bhushan. We'll have a talk, and I'll show you exactly what I mean. Okay?
Sure.
Okay. Thank you very much, everybody. Stay here. I'm going to stop.